Good morning, everyone. My name is Sandya Subramanian. I am an assistant professor in CPH. We've spent a lot of time over the last few years discussing the theoretical potential of AI, the what-if scenarios that dominate headlines. But we've reached a point where the conversation has to change. We're moving to the what is. We're moving out of the controlled environment of the lab and into the unpredictable high-stakes reality of the clinic. The front line isn't just a metaphor. It's where these tools meet the actual friction of patient care. One of the things we're seeing as we deploy these systems is that the human-in-the-loop concept is a lot more complex than it looks on paper. We have to ask, who's actually at the interface? Is it the patient, the provider, or a silent background process? Each of those paths changes the dynamic of trust, and more importantly, the dynamic of risk. When an algorithm influences a decision, we have to be very clear about who's supervising that output and who ultimately carries the responsibility when things don't go as planned. There's also the challenge of AI literacy. It's not just about building a tool, it's about ensuring that the people who are using it understand its limitations and the nuances of how it was built. This leads to a bigger question of governance. How do we choose the problems we're trying to solve? Often there's a disconnect between what's technically impressive and what's actually useful for a clinician facing a bottleneck. We're here today to look at that gap. To help us navigate this, I'm joined by Paul Tang, adjunct professor at Stanford University's Clinical Excellence Research Center, Maggie Chung, assistant professor in the Department of Radiology and Biomedical Imaging at UCSF, Elisabeth Askin, associate professor of clinical medicine at UCSF and co-author of the Healthcare Handbook, and Stacey, Tinianov, founder and community strategist at Advocacy Action and a dedicated patient advocate. Our panelists aren't here to talk about what might happen in 5 years. They're here to talk about what's happening right now.
Great, thanks. So I'm going to give a quick talk about Ambient Scribes, AI Scribes. You've heard that it's one of the fastest adopted AI project in healthcare. And the question I want to put for our discussion is it getting at the root need or the root cause, or is it treating a symptom? So first, what's Ambient Scribe? It's basically automatically transcribing or translating what happens in the exam room into a clinical document. So we'll start with an audio recording of that conversation. We'll use AI to translate that into a transcript, then use AI to turn that into a clinical document, a progress note often. But what's the problem to solve? What's the underlying need? What we'd like to do is have an accurate rendition of what happened in that exam room. That means we want to see the information that was uncovered during that conversation. We want to understand the rationale for the physician making recommendations, what was the decision-making process, and what were the plans and the expected output. Why? Because the next person who sees this, could be me, could be others, wants to know what was planned, what was expected, and if that didn't reach the expectation, what do we do differently? So what's the problem? The problem is this has turned out to be a burnout process for docs. Why? It takes us a lot of time. You all know from your own experience with the doc, half the time the doc is looking at the computer, just as that diagram that Bob showed, rather than the patient. And half that time or more is dealing with these clinical documents, either foraging for the information we're looking for or creating more documents for other people to forage in. Now, that causes a cognitive burden, and that leads to that psychological burnout problem. So AI Scribes is trying to help that. How's it doing? Well, it turns out it does quite well in terms of surveys of physicians' perception of their burnout. It has reduced in one study from 52% to 39%. Different question whether we want 40% of our docs to be burned out, but it is definitely better. What about the time piece? Not so much. Maybe save 30, 40 seconds per note, and in some studies not even statistically different. So we get sort of a happy face for the reduction in the burnout, which is a symptom of the underlying problem to solve. But let's go back to that underlying problem. We need to have accurate rendition to capture and communicate the information needed to take care of this patient. For that, I think we have a bit of work to do. In this study looking at 5 commonly used AI Scribe products, using human physicians as reviewers, it turns out that first piece going from recording to transcript, on average there are 14 errors per transcript. And what's an error? The humans considered it an error if that change, addition, subtraction, what could produce substantive difference in the content. And 20% of those errors carried on all the way to the output of the note. So big deal. What about that second phase, AI transcript to the scribe output? About 16 errors per output. Now, most of these were errors of omission, 3/4 of, in fact. And then people would say, well, let's just throw a human in the loop. And you heard Bob talk about the fallacy of doing that. But the other thing to think about is omission. So it's one thing to go look at something and say, that's wrong. It's another to not look at something and say, what's missing? What don't I know? On average, about 3 errors were judged by the human reviewers to potentially cause, if you relied on that information, moderate to severe harm. Not so cool. And in 13 cases during their study, it could lead to severe harm or death. What's an example of how that could happen? Well, the doc said in the encounter, you know what, I think we need to admit you to the hospital right now because I think you might have sepsis, which is a life-threatening infection. And the output of the scribe said, an admission was considered if an infection could be confirmed. Very, very different. So that's an example of what could come out of this if we're not careful. But that's the key thing, the message here is if we're not careful. So right now we're doing a great job at reducing the perception of burnout. We need to also pay attention to the accuracy of the output. We need more robust evaluation of that. And if we do, one, we will make better products because we'll know how we're failing and how to improve on that. And the other thing is we really need the docs who are using this, relying on this, and the patient's care that's relying on this to know what's the possible harm that could come out. Thank you very much.
Thank you so much. So my name is Dr. Maggie Chung. I'm a breast imager at UCSF. So I interpret a series of many different types of breast imaging, help diagnose and coordinate care for breast cancer patients. And the topic I want to focus on is how can we identify the right problems to address with AI so that we can really have the most impact from our developments. There are a lot of radiology tools that are available nowadays, but I would argue only a very small handful of them actually reap direct benefit for patients. Our North Star should always be how can we identify something that can create the most impact for patients and bring the benefits back to them. And so I'd like to share experience from one of the cooperations, one of the studies that came out of CPH. So as a breast imager, I interpret screening mammograms and coordinate care for breast imaging patients. And one of the core problems I see is that for many patients who go on to eventually be diagnosed with breast cancer, their journey often scales from days to weeks. And the reason being, most of the patients will come for a screening mammogram. They will leave the facility before they get their answer or their assessment on the screening mammogram. If something is abnormal, they have to come back either another day or weeks from now. And at that diagnostic evaluation, if something is still present, they have to come back yet another time for their biopsy. Now, this is a journey that spans weeks to months, and during that time, patients are waiting at home, anxious whether or not they have cancer or not. Now, studies have shown that if you can expedite that, meaning if you can provide answers same day, faster evaluation, that this overall greatly improves patients' experience and improves whether or not they come back next year for their screening mammogram. And we know as a whole, this can reduce care delays and also reduce disparities in breast cancer outcomes. So we know there are many benefits, but the reality is that as a system, we don't have the resources to offer same-day expedite evaluation for all patients. So at the end of the day, this is a resource problem, meaning we have some limited amount of resources. How can we allocate this to patients who need it most so that we can improve their care, and because we know they're the ones who most likely have breast cancer and we can make the most impact in their care? And so working with Dr. Adam Yellow, whom you've heard from before, previously he developed a breast cancer risk model. The inputs are standard screening mammogram, and from that mammogram, model can predict patients' future risk of developing breast cancer in the next 1 to 5 years. And so leveraging that, we were able to implement an expedited workflow for patients, meaning patients who would come in for their screening mammogram, we ran their model in real time, and so even before they leave their room, we know whether or not they're high risk. If they're high risk, then we offer them, would you like to stay for your screening mammogram read? And hey, if we see something that's abnormal, we can do additional imaging evaluation today so you don't have to come back another day for another visit. And some patients, if they have a very suspicious finding, they're even able to get their biopsy the same day. And so in this pathway, we could potentially shorten someone's breast cancer journey from weeks to potentially 1 day or within the week. And, go back. And from this, we were able to shorten patients' screening time from screening mammogram to result and diagnostic evaluation by 99%. And for our patients who went on to have cancer, also decreased their time to a biopsy by nearly 90%. And so what I would like to impart today is so much of it is identifying what is the key problem to address. It's not about what models can we build, but what are the questions that need to be solved so that we can bring better benefits for patients. And once we can have that in place, the technology will follow. Thank you.
Great. I'm Elisabeth Askin, and I do not work in AI. So my comments are going to be a little bit different. I work in quality improvement. So I'm a primary care physician here at UCSF. In primary care, it's a wild world. Basically, you have a bunch of patients who come to you from all different walks of life, and sort of everything that they perceive as health-related is within scope for you. So that can be chaotic. You have to be very flexible. And the logistical, clinical, and administrative burdens in that world are very high. I think it's always useful to sort of situate my work within the ecology of care, which you can see, I put up a little graphic of that ecology right here, and I work in that red underlined section, which is about where 20 to 30% of patients come. My work is also in quality improvement. Quality is this amorphous term that we haven't really defined yet. Despite that, we have to report on a lot of quality metrics, and we have to meet those metrics. That reporting can be quite onerous. Implementation of quality improvement is really hard. A lot of my time is spent on trying to get data and then trying to get people to do what we want them to do, and it's really hard to change people's behavior. And then actually seeing outcomes and results takes time. So this work is not fast. Just personally, I'm skeptical and risk averse. That's the way I view tools. That's the way I view AI as well. And I view AI as a tool within the world in which I work of quality improvement. I wanted to talk about just 3 sort of lessons or constraints for how I view quality improvement work and AI within that. So the first lesson is that stupid things, like really stupid problems, can be real obstacles. So improving people's blood pressure and managing hypertension is a really important problem, and it's an important problem for which I need data. I need data on a population level as well as on an individual level to make treatment decisions. Now, even when my patients remember to take their blood pressure at home, even when they remember to send those blood pressure readings to me, they can send them in about 10 different ways. I took both of these photos actually from IDA. One is where a patient took a picture of their blood pressure cuff machine every day, and the other is where a patient took meticulous handwritten notes of their daily blood pressure. Now, I can receive all of those, but the EHR accepts one way of inputting blood pressure, which I'm not going to do. This is a problem that we've seen for 10 years that hasn't been resolved at UCSF and is a major barrier to improving hypertension control across the population. The second thing I'll note is that relationships are paramount. Relationships are what grease the gears, or even are the gears, in my line of work. I took this quote from an article by informaticist Isaac Cohane in 2017, in which he talked about managing sort of mini AI program for his mother for her heart failure data over a months-long period. And I'll pull out the quote. He says here, "How does a computer program obtain trust and persuasive powers so that skeptics like my mother will comply with recommendations?" Going further from this is a program where Isaac Cohane was calling his mother every day. And sure, he improved her heart failure management based on that data, but for her, how could AI ever replace a daily call from her son, right? So relationships are often what actually improves care. Third, a tool, AI as a tool, can't solve bad policy. So some of the areas in which we see AI in the clinic or in the healthcare system are solving a problem, a regulatory problem for our clinic or for the system. But that doesn't mean that the regulatory problem itself couldn't be resolved without that tool. So one example is of the AI Scribes. These are very popular in my clinic. They can resolve that problem of meeting regulatory requirements around documentation. But we could just as easily, or maybe not as easily, but we could change those requirements to make them less onerous and make them more helpful for clinical care. The same thing goes for quality reporting. AI can help us in some of that reporting, but a bad metric, if it's easier to report on a bad metric, that metric is still detracting from useful care. And then finally, I have also done work in terms of risk adjustment across a population. AI vendors might help you do that work really well, but is that over the, and in the system, is that really solving a problem, or is that just helping sort of meet the system, game the system better? And then in the interest of time, I will skip my last slide.
Stacey Tinianov, I am a patient, I am an advocate, and I am thrilled to be here. So thank you to the organizers for including a patient voice. So I want to go from the clinical reality to the personal reality. So I mentioned I am a patient. I have been living with an autoimmune disorder for a long time, actually longer than it was even diagnosed. I am entering menopause. Everybody looks pretty young here, but when you know, if you know, you know. And I'm almost 13 years out from an early stage breast cancer diagnosis. And I could probably talk about my personal experience with each of these pieces, but I'm actually here today to talk on behalf of a patient community. And again, I work in cancer primarily. So these are the faces. Some people are still here, some people are not. Some people would still be here if we had made enough progress 10 years ago with where we are in diagnosis, in treatment. I'm incredibly motivated, and I consider myself an early adopter. But not everybody is. And there's a lot of confusion today. It's AI this, it's AI that, it's AI everywhere. There is no distinction to the lay community on what's the difference between generative AI, an LLM, machine learning. And so I think when we think about how we apply these things in clinic, we need to think about the homogeneity of the population we're applying them to, the homogeneity of the diseases and diagnoses that we're applying them to. And already today I've heard in this specific panel the things that I want to touch on. I did a brief advocate survey. So as mentioned before, I run a collaborative, I run a nonprofit organization of individuals who are all advocates across a variety of cancer types. And I said, hey, I'm going to be on stage. I'm going to be talking about the patient experience with AI. What do you guys think? Do you use it? Do you trust it? Do you trust it with your health information? And so I don't need to read this to you, but just kind of the highlights. Everybody's using it. Everybody's using it. They're using it to make their emails faster. They're using it to create frameworks for presentations. They're not necessarily trusting it. And they're not necessarily believing that their data is safe and private. And I think that's something that everybody in this room needs to be aware of, because we can be excited about what the output's going to be, but if we're not getting the inputs because people are resistant, then we're never going to get to that more utopian state. Before I was in cancer, I was in tech. And again, you guys look really, really young, but raise your hand if you've ever heard of Geoffrey Moore's Crossing the Chasm. Okay, a few of you raise it. Be proud. Be proud to be on this planet in 1991 when that was actually released. I worked in tech, and this was and still is a bit of a Bible, and it's about adoption, right? So it's nothing to do with health, but a lot to do with tech. And this talks about when you introduce something, you're going to have people just salivating to get their hands on an alpha, to get their hands on a beta, to give you feedback, to say, oh my gosh, this is the best thing since sliced bread. I've lived in the Valley for over 20 years. I've been one of these early adopters, one of these innovators. But then you reach this gap, and you're like, how do I take a technology, and how do I get it out to the masses? And there's a lot of different ways you can do this from a marketing perspective, but we're talking about health. And so before you can cross that chasm, you have to be meeting an unmet need. And so in the rare disease community, there is a huge unmet need. People are not being diagnosed. Nobody knows how to diagnose them. So we're going to AI ourselves. We are the ones that are putting our entire medical record, or the pieces we can find and get access to, into something like ChatGPT, totally open, totally not safe, totally not private, and then waiting for results to come back. We have success stories, and that should be the scary part. If we're finding success outside of the clinic, or what we feel is success outside of the clinic, there's going to be a huge disconnect. So again, eager for the conversation. I do want to leave you with this. I do want you guys to scour the annals of Google and look up Geoffrey Moore's Crossing the Chasm, because again, I think it's relevant. You guys want to adopt. You guys want individuals in the clinic to adopt. We want to adopt, but we need to identify the need. So thank you. And I don't...
Thank you, all of you, and for those very, very interesting lightning talks, and that actually helps me understand a lot of the perspectives on the stage here. So I think across the board, we heard a wide variety of examples of where the AI kind of plugs into the system, right? So in terms of who's interfacing with it. Is it the patient? Is it the provider? Is it somewhere running in the background that neither person is directly interfacing? And I'm curious kind of to hear your perspectives on how do we, I don't think it's an option anymore to say, you know, should we have it be in one place or another? It's everywhere. How do we make it so that the different people who are interfacing with the AI at different places or different AI tools how do we minimize the friction between them?
I think an important part of that is, so for example, in our implementation, it was the radiologists who were reviewing the risk scores. I think as we already acknowledged, AI is being used everywhere. There's still that trust gap. And I think it's very important that whoever the user is, whether it's the physicians, the patients, we need to give them an opportunity or information to audit and oversee that. I think there's one thing to put all your information into ChatGPT and get a list of answers, but you have no way of knowing how accurate is it on a whole for 1,000 patients, what are the results and what are the long-term outcomes of that. When we implement it into we have safeguards, we constantly monitor, is it overcalling for patients, is it undercalling, what are the correlation with who actually has cancer later on. I think maintaining that is really important, and also building that trust in the long term.
I mean, I look at our use of AI as shared experience, just the whole patient encounter is a shared experience. Both of us should want the same thing, which is getting accurate information to pass on to people who have knowledge and applied judgment. And so I want us to be transparent, both in what it's doing for us and can help us with, but also what's its limitations today. like we said, this is the worst model we're going to use. So it's going to get better, but if we don't have our eyes wide open, then we won't know how to advise the model builders to do a better job. But I think we have a shared vested interest in this, and the more we work together, and this model can help, the better.
Is this on? Okay. Well, to a certain degree, I just have trouble answering the question because I think AI, well, I call it a tool in my talk, but it's really a collection of tools, right, that are just wildly different in terms of whatever purpose you're using it for. Much like in the world of quality, what you mean by improving quality is wildly different based on the context. So I suppose, I'm just going to give a non-answer and say I think it's just highly context dependent, but I think understanding trust or how you build trust is key across all of those domains.
Yeah, I will say, again, I'm going to go back to unmet need. And, when you mentioned the radiology application, it took me 10 days from biopsy to diagnosis, right? And that's a frightful 10 days. That is a need that the patient community can get around. When we talk about scribes, I am one of those people that if you look in my chart, it tells you that I have a BRCA1 mutation. I do not. We had a conversation about a BRCA1 mutation. It ended up in my record. It was never caught, and then now there's a little addendum. So again, it's a need, but I would rather have my physician facing away from me capturing an accurate medical record than looking at me and having a wrong medical record. When we get to quality, quality is a really amorphous concept to patients, right? Is quality good communication when there's a lag time in the waiting room? And if so, can AI help with that? Is quality a patient satisfaction score with regard to time into an appointment, and can an automated scheduler help with that? If so, you're meeting a need, and we are super excited to get behind that.
So I think this is a recurring theme that'll come up a lot today, which is the idea of how do we evaluate, or how do we measure, how do we evaluate impact, and if you want to put a positive spin on it, say success, but the question is, how do we evaluate the impact both in ways that we anticipate and in ways that we wouldn't have anticipated to begin with, but we still need to capture impacts, and ripple effects that we might not have known were going to occur. And how do we measure impacts when they compete with one another?
I'll draw on what Stacey just said in terms of going after the need. It's really the problem to solve. The more we understand that, the more we'll even know how to apply our technology, not be a hammer, and then how to evaluate whether we're doing something worthwhile. The method I used in every major project is ethnography, which is observing things in the field rather than relying on people, what do you need? Because if you actually go follow us and actually attend the workflow that we have, you'll see how much opportunity there is for improvement, and also the underlying need that we're addressing, that we would like to address. If we apply AI to that, then we'll really do wonders.
When you mention that, it reminds me of a quote that I've heard attributed to Henry Ford. Don't know if it's true. You'll have to Google it. But Henry Ford said when asked why he created the car, and he said, well, if I had asked people, they would have just wanted a faster horse, right? They didn't know what's possible. And I think when you think about the patient community, it is an incredibly homogeneous community. And we're sitting in a room, in a place, in a country that is highly, highly, highly tech literate, that is highly, highly, highly educated. That doesn't mean that that people are health literate. Usually you don't become health literate unless you go to school professionally for that, or unless you get a disease and then you kind of, need to learn. I will say, though, that asking people, there are people who know what they need. there are people who know gaps, and again, I identified myself as an advocate in the community, and that's what we do, right? We translate between research and clinical care to the patient community and then back again. So if you were interested in creating a project and wanted to work in a specific area, I guarantee you there's a community of advocates in that space that would help you identify a project that would have support.
I think great point was mentioned earlier that benefit and quality can come in many different forms. So whether that is, are we shortening patients' workup time, or are we improving their overall experience so that they're more likely to come back next year, or are we truly capturing a very enriched subset, how accurate the model is flagging the right patients. So there are many different forms that can come in, and there are also trade-offs, like, sure, we are expediting care for the subset of patients, but because we're doing their workup, there's a lower threshold to getting more imaging. So we also need to account for, are now the radiologists getting more imaging on these patients, leading to more false positive flags and unnecessary workup. So these are all things that need to be taken into account. And I think in the prior session, we kind of talked about what will be the physician's role as AI becomes more sophisticated and is more widely adopted. And I think that's where the physician will have a guiding hand in weighing these different benefits, because sometimes they do come at the cost of one another.
I guess I'll just add, so the question is, how do we evaluate the use of AI tools, right? And I mean, I think that's a really good question, because I don't know, and I don't think any of us know right now. You can evaluate things in a really narrow way. And then, like I was trying to show that ecology of care, you can have a perspective that's a really big, long-range perspective of, like, have you improved health in a much larger meta-level way, right? And, I think one of the problems with AI tools, and where some of my own sort of risk-averse skepticism comes in, is that I don't think we've figured out how to evaluate AI and its impact in healthcare.
I'll give an example in terms of evaluation and the real problem to solve. So we're focused in on the textual document called a clinical documentation. And now we have an automated way of turning conversation into textual document. Do I really want to read another short story is the question. I actually want to get information that would help me track what's going on with this person, what has made it better or worse. That would help me make the next decision. Can that be rendered as a graphic that would be easier for me to absorb? Yes. So do I really want to have more text documents, more short stories? That's sort of the, so what are we evaluating? Do I have the information needed to make the best next decision? That would be the evaluation, not the words on page.
Maybe let me ask, in all of your experiences, have you seen an example of something that you thought was well evaluated, or any example of something that you think is a good evaluation, or at least a piece of an evaluation to carry forward?
I think the question's hard because you're, again, my big question mark on my slide, right? AI is a huge space, and we haven't even fully defined what that space means, right? And so you can have these mini projects where maybe it saves some time. You can have some mini projects where maybe it's getting you, the right answer out of a massive amount of data. And so the success of AI implementations, again, to your point, like, are we solving a problem that needs to be solved, and what are we actually trying to solve for, I think is really, really important. But I also think that when we just look at something and say, okay, I've got this AI tool and now I'm going to apply it to here, rather than taking a systems approach and saying, I have a problem, I need to solve it, and AI is a component of that, then I think we can identify the right evaluation and metrics to determine whether or not it was successful.
Yeah, agreed, completely, especially from the QI world. And the other thing I'll add to that is that defining progress, defining a metric is really hard. A lot of things are not measurable. And a huge problem in the world of quality is to focus too much on what you can measure and to miss out on all of the things you can't measure. And the same problem exists for how you evaluate AI and whether it's helping to achieve what you want it to achieve.
I think that's a great point about we're often just measuring the things that are easy. It's easy to measure how much time the physician is now spent documenting, how much time from screening mammogram to screening result. But at the core, what we're trying to achieve is this actually helping patients' outcomes and the direct benefits? Is it helping the physician make better decisions? Does it mean patients are more likely to come back next year? Are they going to have surgery sooner because we got their diagnosis? Is that actually improving long-term mortality? And these are very complex things that take very long to accurately measure. But it should be the overall systems goal, and we should think about thoughtfully how can we build towards that.
So I want to transition a little bit to talking about kind of AI literacy in some sense, which is what do we think is an appropriate baseline level of literacy that we would want everyone who's participating in the healthcare system in some form as a stakeholder to have? And would that change based on, obviously that might change based on what role they have in the system, but what do we want them to be aware of? That there is some sort of tool being used and that's enough? Or would we want them to know more about the tool? Like, what is the appropriate level that we would want, a patient, for example, versus a provider to know?
I sort of alluded to in my talk, people need to know, people who are consuming AI output need to know what could potentially go wrong. So when we sold the Scribe, it says, we're going to reduce the time you need to write down. That's just great. And I'm a supporter of Scribe, by the way. But the doctors who are using it, including myself, don't know essentially what could be going wrong so that we can provide oversight. Same thing almost in spades, just like Bob was talking about, who is the consumer of the AI? When we're exposing it to people, I hate calling them patients, it's consumer, it's all of us, we also need to inform them what could potentially go wrong as well. Because we all know how well it speaks to us. It's very convincing, and that's actually part of the potential for harm. But we need to advise them as well on what to look for and how to confirm. And it turns out by surveys, people do bring it to us physicians to sort of verify, but they need to know how important that is. Because the other study that out of Mount Sinai showed that the chatbot under-triaged 50% of the folks who needed to go in ER, for example. So they just need to have those kinds of awareness so they can be better prepared to read this stuff. And also on the doc side.
I would say it's really important to know what kind of artificial intelligence you're using, right? Are you using a predictive AI? Is this going to come up with something and it's going to be instructive to you? Is it going to be listening and kind of documenting and pulling out and summarizing the salient points? There's different risks associated with each of those. Also, and I'm married to an engineer, so the whole GIGO concept, garbage in, garbage out, people are using large language models and it's phenomenal what can be pulled out of there. However, if your large language model has a bunch of data in it that is out of date, that is no longer relevant, that is from maybe a less than reputable source, to your point, the harms could be very, very great. And so I think just a general, we need to maybe not just use AI with everything. We need to say, we're using massive computing power and that's magic, right? And it is. But also, maybe not look at it as the cure-all for everything, because it's likely not, which is job security for probably all of you.
I think also helpful to share with the users, whether it's providers or patients, planting the seed about, you should be considering your privacy of your data, and then being able to know ahead of time whether or not it's safe and how it will be used.
So I want to have one more question before I open it up to audience questions. If there's a lot of students in the audience or a lot of people kind of starting off their trajectory in this field, what would be, if you wanted them to take away one thing from our conversation here, from your perspective, what would you want them to take away?
I would worry about the hammer problem, especially in the PhD world. And I work with PhD students at Stanford and CS. And they really love when you can get a mission-driven goal. And the way to do that is really to understand the problem to solve. I can't oversell that. It's basically, and it's ethnography, not just asking again at a focus group, what would you like? It goes back to the horse and buggy thing. If you were just to observe what goes on in real practice and how whatever clinician or health professional is working with both data and the patient, you'll see plenty of opportunities. So in a sense, it's go find the high impact problem to solve, and that just brings you additional energy because it creates a mission for you and your PhD projects.
Exact same sentiment, different words. I call it the unmet need. I will say that, spend some time in the community that you want to impact, back to the mission-driven goal. And also, advocacy is a thing. We regularly, depending on what health community we're advocating in and for, we advocate with them. So if you have a question, find somebody in a disease type that you're looking to impact, and we have plenty to say.
Well, I have the same answer as both of them. So I'll give a different answer, which would be my secondary thing. So the slide I skipped was going to be the Dorothy Jackson test, which is a made-up name. I used AI to generate the name and AI to generate a photo, but I skipped it, which is when you are designing a AI tool to solve a problem, think of someone like my Dorothy Jackson, who is completely different from you and everyone you know in terms of abilities and preferences, and think of how your tool is going to work for them. Because, again, in my world, we have to meet the needs of a wildly varied population, and so we need to be thinking about meeting the needs of people who are different than us.
I think once you identify the unmet need, beyond just now building a high-performing tool, it's also understanding the whole ecosystem of where that problem lies. And so your tool, once it's developed, it's going to be a small piece in an entire workflow, and really have to have a sophisticated understanding of what comes before, what's after, and everything around that to make sure that implementation is smooth, so that once you have a great performing tool that's addressing a need, it can be sustainable and reach the impact that you want.
Thank you. Now I want to make sure we have at least a couple minutes to get some questions from the audience. If people have questions, someone is running over mics, don't worry.
Thank you so much for the presentation. My name is Hugo. I'm a patient advocate as well. I have a comment and a question. The comment is about what is the appropriate level of health literacy for a patient, for example. And when I think about that, there's a question that's hidden sort of behind that question. And the question is, appropriate for whom? Is it appropriate for the physician workflow? Appropriate for the institution? Is it appropriate for whom? And so, I think when we think about health literacy nowadays, and I think AI is really a wave that is changing a lot of things profoundly, and it will change everything profoundly, whether we're ready for it or not. But when we think about health literacy, in the old way, health literacy is really about compliance. And with AI nowadays, in the hands of patients, not institutional AI, patient-directed AI, we are seeing really a level of agency that we haven't seen before. So I just want to caveat that in terms of when we think about health literacy, is it about being literate enough to comply, but not too literate to push back, right? The other comment I want to make is about AI scribes and sort of a question about accountability. And I'll give you an example of what's happening I'm a caregiver to my dad, who's 95 years old, and his primary care doctor uses an AI that was assigned, again, to bring up the term institutional AI versus patient-directed AI. I want folks to sort of hold that in the back of their minds. When the primary care physician that sees my dad, wonderful, hardworking doctor, she has been assigned an AI scribe, and that she absolutely abhors, and she doesn't like to use it, and this has created a problem for her, and for us as well, because now it takes her longer than a week to review, to complete her notes. And so one of her recent visit in February, she sent us to an urgent appointment for a nephrologist, and we were not able to schedule the appointment because nephrology did not have the clinical notes. And so I am having to call the clinic to pester the poor woman that's already overworked and seeing God knows how many patients a day, and to complete her note, which she's already told me that you get the point. That she says I have to go back, and it's a kitchen sink of everything, and and I always have to review it and revise it, and it takes a long time. So my question is, who is accountable when the AI doesn't work for the doctor or the patient?
It's a big question. I want to respond to your first one about literacy. And it's interesting, and I don't know whether that's what they're working on, ChatGPT Health, but guess who is getting a real good assessment of your literacy? It's the chatbot, basically. Just like it keeps the context of all the questions you ask. If we could redeploy that understanding of what both your health literacy, your computer literacy, and your questions, the kinds of questions you ask, we could do a really good job of helping you understand caregiving for your dad, as an example. I really like the open evidence approach of requiring an NPI, meaning they understand that it's not as if you can put the same response back to the general public and do good. So that's a simple manifestation of making sure we tailor the response to the person who's executing the prompt. So I just thought, as you talked, it seems like the entity that knows you the best actually are these chatbots, and they could take advantage of that to give you direct responses that just fit your, quote, literacy in all dimensions. And that, by the way, sets you up for the visit with the professional, the doc.
I love that. You bring up the point, and Hugo, you bring up the point that, health literacy, tech literacy, none of these things are static. Like, the more you interact with the system, you're learning, you're having, an experience. I will say that, and you saw it on the brief little survey results I did there, trust is a problem, right? Trust is a problem. And so when we talk about building a relationship with an AI, there needs to be some level of trust where people are going to want to have that same experience again. Right now, a lot of the people I interact with, they create their incognito window, they never log into to chat, and they ask it questions and then they move on. So it doesn't have a chance to get to know you. And so I think that's a responsibility of the platform to make sure that they're trustworthy.
I'll just add in a narrow sense that it sounds like your dad's doctor should be allowed to opt out, right? Like most of the doctors in my clinic use an AI scribe. I don't, for a variety of reasons, and that's fine. And so that kind of goes to that point too, right? Of like, people are very different in terms of preferences and capabilities, and we should be able to design for that variability in this case among many others.
AI is a tool meant to help enable us to do better work, and so if it's not, we should always leave the autonomy to the users. And
more questions?
Just to keep the questions going here, I just want to, as a clinician, I also want to emphasize the message to the students here about the absolute importance of talking to and getting to know the people who are actually involved in this, including the patients. And not just one patient, not just a couple, but many, because they are as varied as all of us. I wanted to, Paul, your comment about you don't want to read stories. You don't want to read stories in the, yeah. I'm sure you didn't mean that completely, and it just brings to mind to me what seems like a really, really low-hanging fruit. And that is that it's virtually a universal need for all of us as patients to have our healers understand who we are as a fellow human being. And we don't do a very good job of that. Primary care doctors like Elisabeth do, but even all of them, because of the workload, don't necessarily know their patients, or they forget the patient's story because they're so busy. It seems to me that this is a great way, if it isn't already being done, of using AI to interact with the patient before the visit to come up with a summary of who that person is, how they'd like to be seen as a fellow human being, and just make that part of sort of a humanistic aspect of the record. I'm assuming that's already been done because it seems so easy. Comments?
Well, I can say something, which is that I'm surprised I haven't seen that be done. The closest I've seen to that is actually a very human version of it at the VA. At least the San Francisco VA had a program in which an individual would go interview veterans about themselves and their lives, and they would actually put that in the chart and send it to their care providers. Another example is actually a geriatrician at UCSF who, when one of his patients dies, sends this beautiful biography he writes about them. I, for a long time, have wondered why we don't have something like the OkCupid matching system, where OkCupid was matching for relationships. Why we don't have something like that for finding the right doctor for you. But I will have to say, I think for a lot of people, their assumptions about their own preferences actually aren't even necessarily known to themselves, or they don't know them on a conscious level, because whatever your preference is, you might just assume is the preference for everyone. And so sometimes you do need prompts to elicit, not just what's your story, but what is important to you. I was coming back to the same thing of your capabilities and your preferences, which again might not even be something you mention unless prompted, because you might not view those as unique to you.
Go ahead. When you enter oncology, for those of you unfamiliar, you have a conversation about your goals of care. And for over 10 years now, I've said I would like that conversation to be about my goals of life. And it's a hard conversation to have, but when you think about treatments, when you think about treatment decisions, when you think about side effects, when you think about toxicities, it really is not just treating cancer, it's about treating the human. And I think the simplest way that I've found is to help people communicate to their teams what brings them joy. Because if you know what brings somebody joy, that is incredibly illustrative about who they are as a person and what their priorities are in life. So.
Yeah, I just want to respond to Dan about the stories. Those are the kinds of stories I would love to read, to understand that person, because the word adherence came up earlier too. That's how you get to adherence, is by knowing what matters to them. What I didn't want to see translated back into words is like your blood pressure. Instead of turning that into words, give me a graph, that kind of thing. But I'd rather read the stories about an individual so we can affect the blood pressure in the A1C. All
righty, I think we are past time, actually. Thank you all of you. Thank you for all of our panelists. Thank you for the questions. And I think we are nearing lunch? Lunch. Okay, great. Thank you.